Ladies and gentlemen, welcome back to Medsynapse, the podcast where we connect you with leading experts in the medical world. Today we have an esteemed guest joining us to discuss the latest guidelines in the management of acne vulgaris. Meet Dr. Maha Sorour, a renowned dermatologist at the Advanced Medical Center for Subspecialties in Saudi Arabia. Also, she's a dermatology specialist in both Dubai and Egypt. Dr. Maha brings over 14 years of extensive experience in diagnosing and treating various skin diseases, including management of sexually transmitted diseases. Dr. Maha holds more than 15 years of expertise in conducting minor skin surgeries. Dr. Maha has over 10 years of hands-on experience in the cosmetic field, mastering procedures such as Botox, fillers, PRP, and mesotherapy. She is well-versed in different laser procedures, including hair removal applications and fractional carbon dioxide. Welcome, Dr. Maha.
Welcome, Nijar.
So, without further delay, let's dive into our discussion on acne vulgaris management. So, the first question for today is, what causes acne vulgaris and what are its contributing factors?
The most common causes of acne vulgaris, as we think, is genetic predisposition, and it's very common and run in families sometimes, and we find them in more in urban areas than in rural areas. We are more found in black and then white races, and we also find it in adolescence period and early 30s. But there is a lot of causes. Most probably, we think maybe related to diet habits, related to hormonal, sometimes related to stress. Nowadays, there is a high concentration of patients because of stress factor, because it makes activation of adrenal pituitary axis. Sometimes kind of medication like lithium, like corticosteroid, like anticonvulsant therapy. Sometimes also cosmetics high relevant, especially bad manufacture type, like cheap items. Also, we all know like bacteria. The most positive, the positive of Propionibacterium acne, the most resistant bacteria type bacteria, and also the most recent is dysbiosis. Of course, dysbiosis is imbalance between, we all have in our skin two kinds of bacteria, good bacteria and bad bacteria. Sometimes imbalance happen and causes overgrowth of Propionibacterium acne. And the contributing factors, I think the most contributing factor and the helping factor in this one is bad diagnosis. We don't make bad misdiagnosis, and not make special guidelines, like special management of this case, like making steps in management and treating of this case, of any cases of management.
Now, moving on to our second question, how can doctors identify, diagnose acne vulgaris and rule out other differential diagnoses which are similar?
We must know well how to make a good diagnosis of acne, but of acne vulgaris. There is considered as a chronic inflammatory disorders of pilospecies unit of hair follicles. Consists of blackhead, whitehead, papules, pustules, nodule, and finally cyst. Sometimes we must make a grading like classification. Sometimes we have mild acne. Mild acne consists of blackhead, whitehead. We consider as comedones. Sometimes like moderate acne, we have comedones plus papules. Sometimes considered moderate severe acne, we consider papule, comedones, and pustules. Sometimes we consider very severe acne, we consider nodules and cysts. We must respect the grading system. And because to make a good differential diagnosis, because there is a lot of differential diagnosis of cases like rosacea, like acne conjunctivata, like acne fulminans, like perioral dermatitis, like folliculitis, like tuberous sclerosis and sebaceous hyperplasia. We must consider good grading system for acne vulgaris cases.
Is there some specific features that general practitioners who are not expert in diagnosing can find a way to diagnose acne vulgaris compared to other differential diagnoses?
They must know acne classification. They must know acne grading systems. There is two types. There is global acne grading system, global acne grading system, and there is also Pillsbury scale. Pillsbury scale, it's the same acne grading system. It's 4 types of classification, from mild to moderate severe to severe cases. All general practitioners must know the grading system, must differentiate between comedones, papules, pustules, must know the nature of skin, from greasy to oily to dry skin, must know the distribution of pilosebaceous gland, because that this is pilosebaceous gland, where is the high concentration, which in face, trunk, upper neck, shoulder, and the back. They must know all these items. It is a principle of general practitioner to know where is the pilosebaceous gland more dominant, because it's a disease of pilosebaceous units.
Now, let's move on to our next question. I'm curious to know how acne vulgaris is treated.
There is a wide range of treatment according to grading system. That's why I told you before, you must learn general practitioner, even youngest dermatologist, how to approach to acne, because it's the common skin problem. It is the most common skin problem. About 80%, maybe about 90% of all of us suffer from acne. They must need how to approach properly and manage the case. They must know that they must begin with make good approach for the case. They must taking good history from the patient, family history. They taking general examination of the patient. They put in consideration what is if she is breastfeeding, she is lactating, if she is pregnant, if she have any problem like Cushing syndrome, like diabetes. They must manage all over the case. They must need to taking history, taking precisely. I told all young practitioners to taking personal history and making physical examination precisely, especially personal history. Diet, how it's supposed to do stress, it's supposed to a special kind of radiation, occupational therapy. They must know how to ask the patient about, especially females, about menstrual history, about ovulation cycle.
Also, are there any new updates or changes in the guidelines for acne vulgaris management that practitioners should know?
We must know the basic guidelines of the acne vulgaris at first. There is a topical treatment for acne vulgaris, and there is a systemic treatment of acne vulgaris. Topical treatment we use from mild to moderate cases of acne vulgaris, like topical antibiotics, topical retinoids. Topical retinoids, we have two available ingredients like tretinoin, adabalene, and azathioprine. We know tretinoin is good. It's normal for normalization of follicular epithelium, and it's good in 40% of cases. And we have also topical antibiotic like erythromycin, like tetracycline, and we have another agent like benzyl peroxide, and we have azelaic acid. This is a topical medication we use. And we have also systemic medication we use, like systemic antibiotics, like systemic retinoids. But in my experience, systemic retinoids, we must take all over precaution, because we fear that systemic antibiotics used for a long time, it may affect the immunity, affect the normal bacteria of our body, and we must avoid antibiotic resistant bacteria. We must avoid these cases. And we have also systemic retinoids, like Reactitan or isotretinoin, and we must precautions with the patient, because to tell him all the data concerning the medication, like side effect, dose, all side effects possible to happen with systemic retinoids.
Now, moving to the next question, are there specific recommendations for pregnant or breastfeeding individuals with acne vulgaris?
My recent recommendation for breastfeeding, and because there is no till now approved treatment during this period, but I just summarize for people to keep diet and to keep away, like hygienic habits, continuous face washing, avoid touching, avoid squeezing, avoid sharing of material of things with patient, and try. The most important thing for me is safety of baby. That's why I keep using the topical antibiotic. I avoid all systemic antibiotics and retinoids. It is a guidelines of lately American Association. Avoid all systemic antibiotic and systemic retinoids. Just topical antibiotics, topical another agent like benzyl peroxide, azelaic, salicylic acid. It is the most safe.
What about using a combination of different treatments together for acne vulgaris? Is it effective?
As you become expert in our practice, we know how to manage and how to put and extract from. We make different because we meet different needs. Sometimes you meet a patient refuse to taking Accutane. Sometimes you meet patient refusing taking systemic antibiotics. We must have special formula with us, like special regimes, like special modification. Every doctor, according to his experience, prefer to begin with topical retinoids because it's effective from 60 to 80% of cases, and with some patient instructions, like I told you before, keeping hygiene, avoid squeezing, avoid putting sunscreen, using face wash more frequently. It's good with patients, but there is cases that sometimes doctor face need systemic and topical treatment, sometimes need laser treatment according to case. I told you before, the grading system is it is the most the most important thing in our management of cases. The most severe cases need combination of all things: topical, systemic, hormonal, sometimes therapy, sometimes we need laser therapy, sometimes need interference surgical, sometimes we need injection, like intralesional injection of corticosteroid, according to grading system, and according to the needs of patient, and it's according to compliance of the patient. Plus, sometimes the patient are in rush. Sometimes he told me just 1 year I need complete recovery of my acne scarring and acne topic. Sometimes the patient is a patient and need maybe 3 years, and slowly, because it's a chronic condition, my dear. It's a chronic condition.
Now, as you mentioned about hormonal imbalances, how is acne vulgaris treated in patients with hormonal balances like a polycystic ovary syndrome, for example? Is it the same treatment strategies that we use?
There is before medication, but not approved by FDA, like spironolactone, like oral contraceptive pills. But now there is a new medication, new instruction from FDA that it's better for PCO. It's control symptoms like keep weight less, keep like if the patient have diabetes, treat with metformin, but avoid spironolactone and other oral contraceptive pills. It is the recent indications from FDA, and try to control. I told you it is put the patient hygienic habits like don't squeeze the pimples, exercise, drink a lot of waters, improve lifestyle of the patient. It is the most common recommendation in PCO patient. Improving lifestyle, not taking medication.
What about the guidelines or recommendations for managing the scars from acne or post-inflammatory hyperpigmentation that results from acne vulgaris?
You know, acne scarring, the most modality treatment is subcision. It is the most recent treatment, subcision and the injection of hyaluronic acid. It is the most recent in acne scarring. Also, according to acne scarring grade, there is also grading of acne scarring. We must know how to, and sometimes in acne scarring we use a combined technique, combined from peeling, from subcision, from sometimes we make we just taping like topical retinoids. We must know the grading of acne scarring, because acne scarring is also a chronic and also not resolved completely. Need time factor, need patient compliance, because some patients expect high expectation. We must learn the patient that he need time, he or she need time for this procedure, because it takes time. But I think the most recent also treatment with blast subcision is also microneedling. Microneedling is also now taking a high prevalence in treatment. Microneedling with radio frequency, and also we non-cross-linked injection of non-cross-linked hyaluronic acid. And I have a paper before also injection of PRP. Platelet-rich plasma is also effective in treatment of acne scar. Plus, we sometimes inject stem cells. We must learn how general practitioners, our young dermatologists, approach cases. They must know the type of skin, because sometimes black skin are more prone to BIH. Sometimes Mediterranean population are more prone to BIH. Sometimes a special kind of medication make BIH. Sometimes misuse of medication, like misuse of topical retinoids, topical peels, like lactic, like salicylic, like mandelic, cause hyperpigmentation. We must learn, young dermatologists, how to properly approach the case. We must learn them how to make good diagnosis, good grading, and good approach by medications. But the most recent and the most novel treatment of post-inflammatory hyperpigmentation is injection or topical tranexamic acid. It is the most recent treatment. There is a topical 5% tranexamic acid, improve in about 70% of cases in a period from 4 to 6 months. But also there is all the treatment, hydroquinone, 4% hydroquinone used for 3 months. It's also a good. But in my personal experience, I love more tranexamic acid, injection or topical treatment. It is the most marvelous treatment.
Thank you so much, Dr. Maha, for sharing your insights on acne vulgaris management based on the latest guidelines. Before we end, I would like to ask about if you have any final words of wisdom or advice for future dermatologists.
I have a lot of advices for them. The first of them, it is good continuous reading, continuous approach to new techniques. Because in our aspect, we have every day, every second, a lot of techniques. And we must be cautious with the guidelines. I told you they must know all the guidelines. Like, we don't begin mild cases with Accutane. We must begin with topical retinoids, topical antibiotics, topical medications as normal. Because the Accutane also have a lot of side effects. And we must sharing all, I make with my patient all strategy, treatment strategy. We must have a lot of treatment strategy. Acne vulgaris special have a lot of spectrum. It is not enough 1 hour to discuss acne vulgaris, my dear. We need a lot of time because there is a lot of information and a lot of impact about acne vulgaris. We must learn young dermatologists and we must young general practitioners that they must keep a lot of strategies and inform the patient because the patient normally sometimes he don't know the impact and the withdrawals and sometimes side effects of all medication. We must inform the patient by the most effective strategy for him and the side effect and the precautions and I told them the lifestyle he must change.
Very wise words, Dr. Maha. I'm sure all the young doctors and future dermatologists will consider the points you have mentioned.
Yes.
Thank you so much for sharing your advices and insights. And before we conclude, we would like to take a moment to acknowledge Medsynapse. Medsynapse is a leading platform that brings together healthcare professionals, fostering collaboration and knowledge sharing. We encourage you to subscribe to Medsynapse to stay updated with engaging discussions and gain access to wealth of knowledge from expert doctors in the medical community. Don't miss out on the opportunity to expand your understanding and stay informed about the latest developments. That's it for today's podcast. Thank you for joining us.